Good morning, dear students. Today we will be discussing about salivary gland disorders. Before we start with the salivary gland disorders, it is advisable we revise little about anatomy, physiology and functions of our salivary glands. Coming to the anatomy of the salivary glands, we have three pairs of major salivary glands and their ducts, and we have multiple millions of minor salivary glands present in the oral cavity. So these major salivary glands, there are three pairs, as I said. First one is the parotid gland. It's present both on right and left side. You have submandibular gland and the sublingual gland, and we have a duct associated with that which will open into the oral cavity. And as the name itself suggests, function of salivary gland is the secretion of the saliva. So what happens in your this salivary glands is there will be production of saliva as and when required, and it will be passed through the duct to your oral cavity. And in the oral cavity, this saliva is used for multiple functions. There are a lot of components in the saliva which are used for digestion, they are having antimicrobial property, they have lubrication property, lot of functions are there. That in detail I am not dealing because you have already studied about that. Remember, mainly salivary gland is present surrounding your oral cavity, and there is a duct. So that duct will pass your saliva from the salivary gland and it will reach your oral cavity for additional whatever functions it is useful, it will be dealt in your oral cavity. So this is the structure, histopathological structure of your salivary gland. So if you see, salivary gland cells are modified epithelial cells. These epithelial cells are the one which secretes the saliva. So these cells will secrete the saliva, and saliva will pass through this duct and reach the main duct, and it will reach your oral cavity. And anywhere there is a disturbance, whether it will be in the gland or it will be in the duct, it will affect the secretion of the saliva. Ultimately, it will affect its function. So today we will be dealing with alteration in this function, which can cause some oral manifestations in the oral cavity. So coming to the classification of salivary glands, we have n number of classifications given by different authors. We advise you to follow Burkitt's classification. According to Burkitt's, there are many different headings what has been given. First category in that is developmental abnormalities. Under that, we have aplasia or agenesis, which means there is complete absence or agenesis of your salivary gland. Then you have hypertrophy or hypertrophy, which means there is increase or decrease in the size of the cell of your salivary cells. Then you have accessory salivary duct. That means normally your one salivary gland should have one duct. In this case, what happens? There is additional duct which can open in the same side or the different side other than your main duct. Then you have aberrant salivary glands. That means the salivary tissue or the salivary gland like tissue is present anywhere along the duct, or it can be present other than associated with the salivary gland. Anywhere it can be present in the surroundings of your oral cavity. Then you have diverticuli. Diverticuli means either curve or bend in your salivary duct. Come to the next classification, where you have obstructive or non-infectious reactive lesions. The name itself suggests obstructive, it is causing obstruction. As I already told, there is a duct which is passing your saliva from the gland to the oral cavity. So there can be any obstruction or reactive lesions within that duct which causes some kind of disturbances or some kind of pathology. So under that, we have Sialolithiasis, Mucocele, Ranula. Then you have next category, that is inflammatory and reactive lesions, which includes necrotizing silometaplasia, external or internal being radiation induced pathology. That means if you all can recollect, epithelial cells are sensitive to radiations. Suppose any radiation is passed through the salivary gland or in the vicinity of the salivary glands, these epithelial cells can get damaged. So these damaged epithelial cells can cause some kind of pathology in your salivary glands, and definitely it will alter the components of saliva as well as it will decrease the secretion of the saliva. Then you have a cutaneous tumor. Then you have other classification called as sialidinitis. Sialidinitis is nothing but inflammation of your salivary glands. So this can be either allergic reactions, or it can be viral infections, or it is bacterial. Any of the etiology can cause inflammation of your salivary gland. Usually it causes inflammation of the major salivary glands, or it can sometimes, in case of allergic reaction, even it can cause inflammation of the minor salivary glands. Coming to the next classification, that is your systemic conditions affecting your salivary glands. There are n number of systemic diseases which can affect the salivary glands. So we have main category, that is your metabolic disorders. So when we take this metabolic disorders, we have most common systemic disease which affects most of the Indian population is diabetes. And diabetes itself can cause some effect on the salivary glands, as well as drugs what we take for diabetes also can have an effect on the salivary glands. Then you have anorexia nervosa, chronic alcoholism, as well as dehydration. Then other category which comes under systemic conditions is medications taken for any disease. It can be maybe for hypertension or any other systemic disease, can have some effect on the components of the saliva, as well as it can even reduce the amount of salivary secretion. Coming to the next classification, that is your immune conditions. In this, you have Mucocele disease, Sjogren's syndrome, granulomatous conditions. Under that, we have tuberculosis and sarcoidosis. Then you have next main category, that is your functional disorders. So what do you mean by a functional disorder is, we all very well know that function of your salivary gland is production of saliva. So under this category, functional disorders, we have either reduction or either increase or decrease in the production of saliva. So xerostomia is reduction in the production of saliva, whereas hypersalivation and sialorrhea is increase in the production of saliva. Coming to the other classification, that is your tumors. So this is a histopathological classification. In the tumors, we have adenomas and carcinomas. Adenomas are benign tumors of your salivary glands. Carcinomas are malignant tumors of your salivary glands. You have n number of diseases in that. Most important adenoma is pleomorphic adenoma, and most important carcinomas are acinic cell carcinoma and mucoepidermoid carcinoma. I am very well aware that these topics would have been covered in your third year oral pathology, and you would have studied about it in detail. Then you have a miscellaneous classification, sialadenosis of sialosis, then necrotizing sialometaplasia and Fraze syndrome. Come to the first disease. I'll be covering in detail about sialolithiasis today. The sialolithiasis means sialolith is nothing but a salivary stone. The stone is similar to the stone what we see in what we would have heard or seen in, it's similar to the kidney stone or pancreatic stone. It's a collection of calcified organic matter which get calcified over a period of time. Initially it will be organic matter, gets calcified. This sialolith can be present within the major salivary gland, or it can be present within the secretory system of the salivary glands, that is your salivary ducts. Usually sialolithiasis is seen in the major salivary glands. Sometimes it can be even seen in your minor salivary duct or the glands. Coming to the etiology, main etiology of this disease is unknown, but definitely for everything there will be some predisposing factor. Here also we have certain predisposing factors which could have caused sialoliths. We have inflammation, irregularities in the duct system, local irritants and anticholinergic medications, altered hydrogen, calcium and phosphorus concentrations. This is when there is alteration in these elements, there is a chance they get deposited somewhere in the body where there are some predisposing factors. So you can see here, I've already explained you about structure of your salivary gland or the duct. Here when we see this black structure, what you're seeing is your sialolith. What does this sialolith do? Initially, maybe it's a small sialolith. It will be present, which is not blocking the passage of saliva. As the size increases, what happens? It completely blocks the duct. When it blocks the duct, that is when the symptom start. Initially, usually patient does not have any symptoms. So what happens here is we can see the ductal system is blocked somewhere. So when it is blocked like this, what happens? Saliva cannot pass through that duct and reach the oral cavity. So definitely in this region, we'll have accumulation of the saliva that can cause swelling in that particular region. So that is the main pathogenesis, what is there associated with your sialolith. Coming to the clinical features, as I already told, it is usually asymptomatic. Why is it asymptomatic? Because main problem what we are going to face here is when the duct is getting blocked by the sialolith, that is when the symptoms arrive. Initial stages where the duct sialolith is very small, definitely it will not be blocking our path or the passage of your saliva. So definitely we will not have any symptoms. As it grows, when it completely blocks the duct, that is when symptoms start. So that's why we've written it is usually asymptomatic. Sometimes what happens when we routinely take a radiograph for some other pathology, we might identify sialolith. Sometimes that is the situation. Or when it has become very big, what will be the symptoms? When it has become very big, it is blocking the duct completely, that is when symptoms start. And where do we see this duct? Which structures we'll see? Most commonly we see in your submandibular salivary gland. There are many reasons for that. Most commonly it is seen in submandibular. Then next common site is parotid. So there are 12 to 15 reasons why it is most commonly seen in our submandibular salivary gland. I want one of the student to find out what are the reasons why it is most commonly seen in your submandibular salivary duct or salivary gland. Roll number 25. It's your duty to find out the reasons, and next class you have to enlist the reasons to the entire class. Okay, coming to the next things, that is your symptoms. Symptoms, what is there is, there will be history of acute painful intermittent swelling of the affected major salivary gland. You remember acute means it is sudden in onset, it is painful. Definitely when there is a block, there will be painful. Intermittent swelling. What do you mean by intermittent swelling? Swelling is not present continuously. One particular point of time there is a swelling, then gradually swelling decreases. So what is the reason for that? Okay, so what is the reason for that is when we start eating, when we initiate eating, or at the sight of the food or the smell of the food can cause sudden enlargement of the salivary gland or that particular site where there is a salivary stone. That is because when at the sight of the food or the smell of the food, or when we initially start eating the food, there will be excessive secretion of the saliva. So that saliva, when there is sudden secretion of saliva, that particular large amount of saliva will not be able to pass through the blocked duct. That is when acute painful intermittent swelling starts there. And gradually when you continue to eat, what happens is that saliva slowly, the whatever passage is available for it, it seeps through the bypasses your stone and reaches your oral cavity. So at initially when you start eating the food, there will be big swelling. Gradually when you continue to eat, swelling will start reducing. Okay, so patient, that is the characteristic symptom of your sialolithiasis. At the sight of food or at the taste of food or the smell of food, initially increases sudden pain and swelling, and that gradually decreases by the time you finish eating your food. That is that symptom you have to remember. Then on examination, that will be the characteristic history what patient will tell you. So come to the examination. When patient has come with such a complaint, what you need to check? You take a proper history and you have to do the examination. So when we do the examination, most of the time what happens, there may not be anything in the oral cavity when you do the examination, until and unless the stone is very big and you are able to palpate it. Otherwise, what other finding you can see is enlarged tender salivary glands. Salivary glands can be enlarged and it will be tender on palpation. So in chronic cases, what happens when this phenomenon is happening for a longer duration of time? The patient might not visit a dentist or any professional for this problem because initial cases it is asymptomatic. When it becomes symptomatic, patient might visit a dentist. By then, it would have already become a chronic case. So what happens in chronic cases? Chronic cases, what happens is there is stasis of saliva in that particular region where there is a blockage. So whenever there is a saliva stagnant for a longer duration of time, there can be infection, there can be fibrosis, there can be even gland atrophy. So when does the gland go for an atrophy? When the saliva secretion, whatever is there, which is not getting used, it is getting going back to the salivary gland itself, it is not functional, that then what happens, that gland can go for atrophy. Finally, when the infection and fibrosis continues, there can be formation of a fistula, sinus tract, or an ulceration. That is the secondary phenomenon after the site wherever there is a calculi gets infected. So clinically, when you're doing examination in chronic cases, you might see fistula, sinus tract, or ulceration adjacent to the opening of the duct or adjacent to the site where there is your salivary stone. So these are the clinical features. If you see in this picture, floor of the mouth, so you cannot see any abnormality here. But clearly, when we sometimes in inspection, we might not see anything. Usual inspection, what we see is swelling. So we may not be able to appreciate the swelling in inspection. But when we palpate, we can, if you palpate the floor of the mouth, sometimes we might feel some hard structure along the path of your duct. Usually your Wharton's duct. Sometimes near the opening, there can be inflammation near the opening of the duct. Here, this first picture, what you are seeing, maybe it's a smaller stone, it is not seen, but we could have made out if you would have done a palpation. But this, we can see here, what is there is a bigger calculi. You can see a bigger calculi that can be seen clinically itself. So it is near the opening of your salivary duct opening, where it is opening in the oral cavity, that is where it is present. So how do you diagnose this condition? History is very important here, because as we told, characteristic history patient will give you, that is the pathognomic history for this particular sialolithiasis. When they start eating the food, there is sudden enlargement, painful enlargement of the salivary gland. Okay, so that history is very important. And patient also gives you history once they stop eating, the swelling becomes small, as well as there is reduction in the pain. So clinical examination, you can do the palpation of the gland, you have to do the palpation of the duct. Duct course has to be palpated to see on the duct course anywhere you feel any art structure, that has to be done. So suppose under history and clinical examination, you get a clue, the swelling or the pain could be related to your salivary stone. What you need to do next is you have to subject the patient for investigation so that you come to a conclusion. Just by history and clinical examination, almost you get 90% of the information. Even then, you have to confirm your diagnosis before you proceed for your treatment. So what are the things which you need to do is you have to go for an investigation. The most common investigation what can be done here is radiographs, because the sialolith or the stone can be detected in a radiograph. So what you will do is you can take a radiographs. Usually what radiographs are taken? If it is a submandibular salivary stone, what we usually take is occlusal radiograph. Because occlusal radiograph, when we take, you can see clearly, this is the occlusal radiograph. You can see the salivary stone, which is taking the shape of your salivary duct. You can clearly see shape of the duct is seen, and you can see even when you take a OPG, it can be OPG or IOP, it can be seen to some extent, but in OPG and IOP, it can be so many superimposed structures. You will not be clearly, it cannot clearly say it could be this only. So it's advisable whenever there is a submandibular duct calculi, take occlusal radiograph and confirm it. Other investigation what can be done is silography, that we will deal in detail about the silography in henceforth classes. But remember, silography is something where we are injecting some contrast agent to the duct to see whether there is anywhere blockage of the duct. Because if you see this image, these two images, when you compare, in the first image you cannot see the duct continuously. That is a normal conventional radiograph what we have taken. Whereas in the second image, this is a silography image. What we have done is we have injected a contrast agent into the salivary duct orifice and we have taken a radiograph. In this, we can see duct is filled with a contrast agent. That can be done in order to identify where there is a pathology. Okay. So these are the investigations. Once we confirm investigation, what is the next step? We have to manage the disease. So how do you manage this particular condition. Initially, what we have to do is we have to give a supportive therapy. So what is the supportive therapy? Suppose if it is an acute condition, acute inflammation is there because of some infection near the duct or in the gland. We cannot do the treatment immediately. We have to give a supportive therapy. We have to try to reduce the inflammation with anti-inflammatory medication. You give antibiotics and analgesic, try to reduce the inflammation. Then what is the next step is we have to surgically remove the calculi. Either you completely slit the, wherever you can see in this particular case, what we can do is we can remove the stone very easily. It is already exposed to the oral cavity. Otherwise, what can be done is you have to either remove the calculi with the duct or the gland. If the calculi is very near to the gland, maybe some portion of the gland has to be removed. Then you have other procedures like endoscopy and lithotripsy. When the salivary stone is small and it is very near to the gland, suppose if you cannot palpate it, you don't know where is the, not don't know, you know where exactly its location is through the radiographs, but you're not able to access through the oral cavity, through the manipulation. If you cannot identify, you can go for endoscopy. So endoscopy is something where we are attaching a camera to the front end of the instrument and we will insert that instrument into the ductal orifice. Through the ductal orifice, proceed towards the gland and identify where is the stone. And through that, endoscopy is a investigative procedure where we can check where the stone is. So lithotripsy is the removal of the obstruction. So what is lithotripsy is, along with this endoscopic instrument, we can attach other instrument which can break the stone into smaller fragments. When it is broken into the smaller fragments, what happens when there is sudden gush of saliva, it is getting removed. Normally, when small salivary stone is there, when how it is getting flushed through the saliva, this also can be flushed. That is one more method of treating your sialolithiasis. So remember, sialolithiasis is a condition which can affect your mainly major salivary glands. Okay, so what happens there is obstruction of your salivary duct. So that obstruction has to be removed in order to treat the disease. So that obstruction can be removed. Sometimes if it is very small, if you can palpate and push it towards the duct orifice, that also can be done. That is the easiest manipulation. Just through the duct, you palpate it slowly, push it out of the ductal orifice. Otherwise, it has to be done surgically. Surgical removal of the duct or the gland, or you can even treat it through endoscopy and lithotripsy. So that is about your sialolithiasis. Coming to the next category of disease, that is your mucocele. This is also one of the most common type of salivary gland disorder. So what do you mean by mucocele is, it is a swelling caused by the accumulation of saliva at the site of traumatized or obstructed minor salivary gland duct. Usually mucocele is seen in the minor salivary gland duct. Sometimes it can be even seen in the major, but very rarely. Usually if it's seen in the sublingual salivary gland. So if you read the definition properly, there is accumulation of saliva at the obstructed or traumatized minor salivary gland duct. In that you have two categories. So you have extravasation type and the retention type. What do you mean by extravasation type of mucocele? See, this is something related to the minor salivary gland. The definition itself, it's there. Remember, it is related to the minor salivary gland. What happens here is there is a trauma to the minor salivary gland duct. So whenever there is a trauma to the duct, so there is obstruction in the duct. So what happens when there is an obstruction in the duct? So saliva, whatever is secreted, that will get released to the different sides. So when it is getting released to the different sides, either in extravasation type, usually the most common sites will be lips, buccal mucosa and the tongue. Whereas in the retention type, what happens is there is obstruction of the minor salivary gland by calculus or contraction of the scar tissue. Either there can be blockage of the duct by calculus, or there can be some trauma in that site. There can be a scar tissue formation that also can retain your saliva within the minor salivary gland or somewhere in the duct. So usually retention type is seen in the palate or the floor of the mouth. So these are the two examples. You can see extravasation type. What happens is there is a duct. Assume this as the minor salivary gland and this is your duct. Whenever there is a trauma, what happens? There is continuation of the passage will be obstructed or it is cut and the saliva is getting spilled somewhere in the connective tissue below the mucosa. So that particular site, wherever mucosa is getting accumulated, there will be a swelling. That swelling we call it as a mucocele. The second category is retention type. Here what you can see is there is a calculus or any mucus plate or any scar tissue which is obstructing the duct. There is no cut in the duct, but there is obstruction of the duct. So whatever saliva is getting secreted, it is getting accumulated in one particular region. That is what we call as a mucus retention cyst or a mucocele. So clinical features what we see is usually there is a discrete painless smooth surface swelling present in the, usually most commonly it is seen in the lower lip. So it will be dome shaped swelling seen in the lower lip. And characteristic history what patient will give is recurrent increase and decrease in the size of the swelling. Whenever there is a trauma, there is a chances there is increase in the size of the swelling and gradually the swelling will reduce, saliva will get dissipated with the surrounding regions and it will get reduced. Then you have what is the characteristic feature is that. So how do you come to a conclusion? Why is this region very important as a diagnostician? Why is it important? Sometimes whenever there is a minor salivary gland tumors or any soft tissue neoplasm of the oral cavity that can mimic your, that looks similar to your mucocele. So you need to remember whenever you're considering a mucocele, do a thorough examination, identify the lesion, make sure that lesion is filled with the fluid and take proper history so that you will not misdiagnose your mucocele with any of this following differential diagnosis. Maybe it can be salivary gland neoplasm or soft tissue neoplasm or vascular malformations, or it can be even vesiculobullous diseases. So you have to consider the following differential diagnosis before you come to a conclusion. Coming to the management, what you are going to do in this management? Most of the time what happens when patient will give a history, there is increase and reduction, increase and decrease in the size of the lesion. Sometimes they are not bothered about. Anyway, it comes and goes. They are not very much willing to go for a treatment. But some individuals are there when it is bothering them, when it is very big, when it is obstructing their daily activity, maybe it is obstructing the speech or mastication. That is when they seek a dentist or a oral physician attention. So in such cases, what has to be done is manage, only way to manage this is surgical excision. Surgical excision of the mucocele along with the involved minor salivary gland has to be done in order to prevent the recurrence. Recurrence in this case is very rare and when surgery is done appropriately. So that is about the mucocele. Remember, mucocele usually it is a disease or the accumulation of mucosa associated with a minor salivary gland and the duct. So there are two types, extravasation and retention type, and treatment is anyway we have to go for surgical excision of the lesion. Coming to the modified variety, or it is a ranula is a mucocele, but it is not associated with the minor salivary gland. It's a term used for a mucocele which is seen in the floor of the mouth. So that's what we call it as a ranula. The name ranula is derived from the word rana, which means swelling or the translucent underbelly of a frog. If you have seen a frog, the belly of a frog usually has a translucent appearance. This ranula looks similar to that. When we lift the tongue, it looks similar to the belly of a frog. Why is it called like that? Is usually whenever there is mucocele present in the floor of the mouth, maybe it will involve your sublingual salivary gland. So it is present as a blue dome-shaped swelling in the floor of the mouth that looks similar to the belly of a frog. That's why it is called as a ranula. And when they become very large, they can even elevate, fill entire floor of the mouth and elevate the tongue. So you can see This is what it appears like. It is a fluid filled big swelling. Okay, and it usually gets filled whenever patient is having food. That is when size increases. Definitely this condition patient will report to a doctor because it is very big swelling. Definitely it will bother the function. There is additional variety that is called as a plunging or cervical ranula. The same ranula, whatever we told so far. Suppose this ranula, it passes below the myeloid muscle. So what happens? The swelling passes, or the salivary components, whatever is present in the ranula, it can get below your myeloid muscle, and it will be seen near your chin. So that kind of ranula we call it as a plunging or cervical ranula. Usually it is present above the myeloid muscle. When it goes below the myeloid muscle, swelling extends to your neck. That is when we call it as a plunging or cervical ranula. Okay. So again, treatment for this kind of mucocele is also a surgical excision of the lesion. Remember, plunging or a cervical ranula is nothing but it's ranula, but when it is extending beyond the myeloid muscle, when it is crossing the myeloid muscle and extending below, that is when we call it as a plunging or cervical ranula. Okay, so that completes your sialolithiasis and your mucocele and classification of your salivary glands. So hope you all have understood the topic, and any doubts are there, you can approach me after the class, or anytime you can approach me during your working hours. Thank you.